Thank you for the opportunity to present on behalf of the team here today. Just to help us introduce the subject, it's really important when we're considering end-of-life care that we don't forget the children. We're reminded by the Childhood Bereavement Network in 2023 that 1 in 18 children experience the death of a parent before the age of 18. That's quite an astounding figure, and that can equate to at least one child in every classroom. When we consider the parents, we know from doing some empirical work with parents impacted by cancer at end of life that they have huge uncertainties of how best to prepare their children and how to navigate this end-of-life experience with and for their children. We, as health and social care professionals, are ideally placed to present and provide support to parents at end of life with their dependent children. But we know once again from our empirical studies that healthcare professionals lack knowledge, they lack confidence, and they lack skills. And from a very recent systematic review, of which we have a poster at the back this afternoon, displaying that it identified 2 educational interventions for health and social care professionals to upskill them in delivering this aspect of care. So we know that there's a dearth of work in this area. So our project was to evaluate the effects of a face-to-face, evidence-based and theory-driven educational intervention to equip professionals to deliver family-centred cancer care when a parent with children under 18 is at end of life. 3 key objectives were to determine if the intervention improved professional knowledge about the support needs of the families at end of life. Our second objective was to determine if the intervention improved professional self-efficacy towards supporting parents at end of life. And our third objective was to explore the perceived impact of the intervention on professionals' practice. So what was the intervention? The face-to-face intervention lasted 2 hours in duration. It was evidence-based, so that derived from a systematic review and also a substantial qualitative piece of work with 79 participants that included parents at end of life, bereaved parents, health and social care professionals, and also funeral directors. The framework for the intervention was the Walsh Family Resilience, a framework for clinical practice that highlights the benefits of open and honest communication at end of life and how this can maintain and sustain parent-child relationships. We also had based the intervention on our talking, telling and sharing framework, of which has 6 key steps within it, identifying why it's important to communicate with children at end of life, the when it's important, where, who, and what are the words. This intervention also integrated 7 videos. These were short videos that captured the key conversations that professionals can have with parents at end of life. And these were co-created with our PPI representative and also clinical staff as well. The intervention also had a bereaved parent sharing her story, which was very powerful and very impactful, and also 2 clinical academic facilitators, myself and Dr. Jeff Hanna, who based his PhD work in this field. So we delivered 14 sessions to frontline health and social care professionals between September 21 and September 23, and their training was accessed by 347 professionals. The evaluation was a mixed methods approach, and we underpinned it with the Kirkpatrick's 4 levels of evaluation, being a well-recognised model to help evaluate educational interventions. We, in this study, were looking at the first 3 levels: the reaction to our training, the learning obtained from the training, and also the behaviour. So we had the quantitative component was pre-test, post-test, of which there was 216 health and social care professionals who completed a validated self-efficacy scale and a number of single item questions. There was the qualitative component, of which 14 professionals were interviewed at least 3 months following the training. So moving into the key findings, in 10 minutes we can't present very much, but we're going to highlight some of the key findings this afternoon. Looking at the level 1 of the Kirkpatrick model, the reaction, and these were single item questions based on a Likert scale of 1 to 5, with 5 being the maximum level with a high response rate. We can see that the reaction to the intervention was very positive, where the workshop objectives were clearly met. There were also, the workshop was delivered at a suitable pace, was relevant to professionals' area of practice, and they would recommend it to their colleagues. Moving on to the learning, we had 2 single item questions here. Again, Likert scale of 1 to 5, and we can see a high degree of satisfaction also with the learning obtained. We can see from the first question that the course content increased the professional's knowledge level, and they also perceived that it was detailed enough to meet their training needs. Moving on to the validated scale, the self-efficacy scale, which had 12 items, and we found that there was a statistical significant difference from pre-test to post-test. Moving on to some of the core qualitative findings, looking at Kirkpatrick's level 4, the impact on practice, and we had 2 thematic areas. The first one, theme 1, impact of the intervention on practice, the power of the art, science and lived experience, where we find that the learning introduced new approaches and new tools for the professionals to help them to progress the supportive care conversations. What they really were finding was the language. This was something that they were lacking, and they were looking for the language to help progress these conversations in clinical practice. There also was certainly a lot of relevance from the educational videos that were produced and integrated and embedded into the training. We can see here from one of the quotes, "It's been 10 months, but the memory of those videos has stuck with me. I've watched them a few times since. In fact, I had a mum who was in the dying phase a few weeks ago, and I re-watched the videos just to remind myself of what it was that I needed to tell Dad." We also find overwhelmingly positive feedback from embedding the lived experience of her PPI. Lisa's story was so raw and yet so real. Lisa really had to pick up the pieces and had to find out a lot of that support for herself, and that's just not right. I've no doubt there's plenty of other parents. And what really seemed to resonate was the fact of hearing Lisa's story, being a bereaved mum with 3 teenage kids, and how she had to navigate this end-of-life experience with limited support, but that desire of support from professionals was really powerful, helping to bridge the gap between the research findings and the real-life encounters. Our second theme was promoting family-centred cancer care in practice. There was this desire for this training and elements of this training to be embedded within the advanced communication skills. What we were hearing from the healthcare professionals who were part of the qualitative interviews was this need for a systems-wide approach for this training to be delivered in more of the core courses like advanced communication skills. There was also a desire for other team members to be able to access the training, so this sense of needing a more sustained model of the training. And again, there was highlighting how the training aligned to practice, but there also was a desire for more challenging situations to be integrated into the training as well, like how to manage if a parent doesn't respond very well, or if a child acts out. So looking for a more detailed training into those more challenging areas of this end-of-life care. So in conclusion, there was a clear need for a sustainable model of training, both within advanced communication skills, but also e-learning. We do realise that there's a requirement for further research to evaluate Kirkpatrick's Level 4 that impact of the training on the families. And we're just pleased to be able to share that we've got some further funding from an impact fund in our university to enable this to take place. We're also very keen that there is a policy change to ensure parents at end of life with dependent children receive the necessary supportive cancer care. We do know in Sweden that it is embedded within their policy that any child under 18 who's got a parent at end of life are entitled to supportive services. And we are meeting with some of our Department of Health in January to look to see how we can progress this to be within policy. We haven't just left our training with the face-to-face training. We have moved on the learning that we have gained from this into an e-learning resource through one of the EGA funded projects with our colleagues from UCD and DCU. And we've been delivering some of the little postcards that you can see on the screen around some of the tables today. And this is now currently available in the All Ireland Institute Education Hub. So we'd really welcome people to visit that. And also we're in the evaluation phase of that project. So we'd really encourage people to engage in the pre and post questions as well. We'd like to acknowledge all of our partners. We had the opportunity to do the training in the 5 health and social care trusts in Northern Ireland and with Cancer Fund for Children. And just to remind you once again, that's the link for the All Ireland Hub. Thank you for this opportunity to present today.